Good morning, everyone. Good morning, everyone. I am Dr. J.G. Sharath Kumar, consultant general laparoscopic surgeon practicing at Apollo Spectra hospitals. Today, I am going to discuss a topic on laparoscopic management of ventral hernias. So, first, coming to the introduction, what is ventral hernia? So, ventral hernia, it's a defect in the fascia of the anterior abdominal wall with or without bulge. So, this is the definition of ventral hernia. So coming to the classification of ventral hernias, it may be primary or incisional hernias. The primary, its incidence of 3 to 5%, and incisional hernia, it's also called secondary ventral hernias. It's in the incidence of 2 to 20%. So coming to the first primary ventral hernia, once again, according to the International Hernia Guidelines, so it classified as midline and lateral. Midline, once again, subdivided into epigastric and umbilical. And lateral hernias divided into spigelian hernia and lumbar hernias. This depends on the site of the hernia, primary ventral hernias. So coming to the size of the hernia, it is subclassified once again into small, medium, or large. Small is when it is less than 2, the defect is less than 2 centimeter. Medium is when the defect is 2 to 4 centimeter. Large primary ventral hernia when the defect is more than 4 centimeters. This is about primary ventral hernia. Coming to the incisional hernia, the incidence of around 2 to 20%. Once again, according to international hernia guidelines, it is subdivided into midline hernias and lateral hernias. Once again, midline is subdivided into M1 to M5. M1 is subxiphoid, epigastric, umbilical, infraumbilical, and suprapubic hernias. Coming to the lateral hernias, divided into L1 to L4. It's divided like L1 is subcostal, L2 is flank, L3 is iliac, L4 is lumbar. So once again, according to the recurrence, whether recurrence are yes or not, it's also classified in the international hernia guidelines as incisional recurrence is there or not, and depend on the length. What is the length of the hernia and width? In the width, it's subdivided into less than 4 centimeter width, or 4 to 10 centimeter width, or it is more than 10 centimeter width in incisional hernias. So these are about the classification of incisional hernias, secondary ventral hernias. So why it occurs? What are the risk factors for ventral hernias? One is smoking, obesity, steroids, patient with cirrhotic liver disease with ascites and portal hypertension, malnutrition, wound infection of the previous surgeries, or technical aspect of the wound closure, the type of the incision used for surgery, laparotomy or any other surgery, excessive tension during suture closure, or the type of the suture material that used. So these are about the risk factors. So how to diagnose hernia? So one is mainly by clinical. So to confirm the size of defect, the content of the defect, we can do a simple ultrasound of the abdomen, ultrasonography of the abdomen. If it's a complex hernia, multiple defect, very large hernia, loss of domain, you can go for CCT of the abdomen to know about the fascia, thickness of the fascia, muscle, aponeurosis. You can go for CCT to plan the type of surgery. So this is about diagnosis. One is clinical and radiological by ultrasound and CCT abdomen. So next, what are the indications for surgery? So first indication is bulge associated with pain or discomfort. That's the first symptom. Next is persistent increase in size of the bulge or size of the hernia. Next, any skin changes associated with the hernia, or once again, skin changes like skin complication, redness or blackish discoloration of skin. This is the one thing. Or irreducibility, cosmetic purposes, and whether there is signs of intestinal obstruction like sudden onset of pain, vomiting, constipation with obstipation. This is the emergency surgery for ventral hernia repair. So these are symptoms of signs of obstruction. So this is the indication for ventral hernia repair. So coming to the main topic like surgery. So during the beginning, they used to do open surgery. Now laparoscopy has become a standard of care for ventral hernia repair. So Lee Blanc in 1993 he introduced the technique for laparoscopic ventral hernia management that's called IPOM. The full form is intraperitoneal onlay mesh repair. So that is a standard of treatment. So now recently we have developed the IPOM Plus. What is IPOM Plus? It's intraperitoneal onlay mesh repair associated with defect closure. That's why it's called IPOM Plus. So the main treatment is prosthetic mesh placement. That's why it's called laparoscopic ventral hernia plasty. So main techniques are IPOM and IPOM Plus. Addition to this, when the defect is large, when there is a loss of domain, you can use a defect cannot be closed properly. Then we can use an addition technique like component separation technique, like it may be anterior component separation technique or posterior component separation technique. Still the defect is more than 5 to 8 centimeter or 10 centimeter, you can go for transverse abdominal release. Some of the fewer techniques called SCOLA, subcutaneous onlay mesh repair, so that's a one, or E-Milos, so many techniques are there. Another technique is TARM, transabdominal preperitoneal repair, mesh repair. Another is called E-TAPE, E-TAPE RS, is also called extended view tape with reverse stopper repair. So these are the different techniques for repair for laparoscopic management of ventral hernia. So these are different techniques. So coming depending on the mesh, where you will place the mesh, which plane you will place, it's also divided into onlay, inlay, sublay, or underlay. When it comes to onlay, when it is placed in a subcutaneous plane above the fascia, prefacial layer, it's called onlay. When the mesh is placed in between the defects, it's called inlay repair. When it is placed below the rectus or above the posterior rectus sheath, it's called recto-rectus repair. Underlay means its placement of mesh, it's within the peritoneum or abdominal cavity. That is called intraperitoneal onlay mesh. Other name is intraperitoneal onlay mesh. So this is about the placement of the different planes. So coming to the technique of intraperitoneal onlay mesh repair. So patient will be given general anesthesia or epidural, and patient will be first, it's a standard 3-port technique. When it's a midline hernia, we'll use lateral ports. When it is a lower abdominal hernias, we'll use a upper abdominal ports above the umbilicus, supraumbilical ports. If it is a upper abdominal hernias, we'll use a lower abdominal ports, standard 3 ports. Always first we'll create a pneumoperitoneum. One is by Viris technique. Then after creating a pneumoperitoneum, we'll create a standard 3 ports. After triangulation, we'll identify the defect and the contents. Because sometimes it will be momentum, sometimes it may be small intestine or bowel. So first, after identifying the contents, first you have to reduce the contents. Following reduction of the contents, you have to dissect the sac also. Sometimes you have to excise the sac. Following which, first then the defect will be closed using intracorporeal sutures, barbed sutures, or sometimes extracorporeally. It's called shoelace technique. So after closure of the defect, you have to place a mesh. So any hernia repair, you have to place a place it's called hernioplasty for strengthening the abdominal wall. So in this ventral hernia mesh repair, laparoscopic, we'll use a dual mesh or a composite mesh. So one layer is a absorbable layer, another is a non-absorbable layer made of a proline. So absorbable layer is facing toward the intestine. So non-absorbable facing to the abdominal wall. So after putting the mesh inside the abdominal cavity, it is brought to the anterior abdominal wall. It is fixed using the transfacial sutures. Standardly 2 to 4 positions, one at 12 o'clock, 6 o'clock, 3 o'clock, and 9 o'clock, using the non-absorbable or delayed absorbable stitches. Following transfacial sutures, it is strengthened fixation by tackers. We usually use absorbable tackers. The technique is called double crown technique. One is inside the edges of the mesh, and around the defect one more circle, we use tackers. That's why it's called double crown technique. So following which all the transfacial sutures are tied, and so between the mesh and the bowel, we'll place a momentum. Then pneumo is released. First, we'll remove the ports under vision, pneumo is released, and all the port sites are closed with port vehicle if it is more than 5 mm, and skin is closed with the observable and non-observable stitches. Trussing is done. This is a simple technique about laparoscopic management of ventral hernias. So coming to the why is the advantages of laparoscopic ventral hernia management? Because it is less pain, shorter hospital stay, early recovery, but it is not less, and associated with early recovery to the go to the hospital. Another advantage is less tissue trauma or axis trauma. When you put a port, it's all 5 mm ports. That's the one thing. But it's a small scar, so better cosmesis, less soft tissue disruption while dissecting and all. Use a harmonic or a bipolar forceps and or monopolar. We'll dissect with a small soft tissue dissection will be there. And during laparoscopy, you can also identify other smaller defect, unidentifiable hernias. That's also called Swiss cheese defect. So it can also be tackled during the same hernia repair and prevent the further recurrence. And also the small incision will be decreased wound infections and less morbidity. That's why laparoscopic ventral hernia is advantageous because of all these points. Why IPOM plus? From IPOM to IPOM plus. IPOM plus means closure of the defect and placing a mesh over the defect. So the mesh you have to cover all around for more than 5 cm from the defect. So it will give a good strength to the hernia repair. So why IPOM plus? There is a less chances of seroma formation. Seroma means fluid collection within the hernial cavity or sac cavity. There will be no mesh eventration. Eventration means when the IPOM plus is done, mesh cannot go into the sac. That's the one thing. There is a less chances of recurrence and better restoration of the abdominal wall functions. And the last one is improved long-term outcome will be there. So for this, we prefer IPOM plus is a good and better technique more than IPOM plus. So any surgery, they will be associated with some complications, like seroma formation during dissection of the sac, or there will be collection of the serous fluid within the hernia defect, hernia sac. So that's the one. And hematoma, bleeding may occur into the hernial sac during dissection. Sometimes there will be a bowel perforation when there is too much adhesions and all. So there will be causing of enterolysis around 1 to 6% during dissection of adhesiolysis or removal of the content from the hernial sac. There will be perforation or enterolysis. So other causes, some of complications are post-operative pain due to transfacial sutures and tacker application. It may cause little pain for few days. So then post-operative ileas due to surgery, to the handling of the bowel and all. Sometimes there will be trocar site infections and fistula formation. Sometimes there will be bowel obstructions, rare causes of recurrence and fistula formation, and some more rare causes of pulmonary embolism. So this is a brief about laparoscopic management of ventral hernia. One is by definition, classification, and what are the risk factors we have discussed, and about the indication for surgery, and what are the types of surgery, advantages of laparoscopic ventral hernia repair, and why IPOM plus is better than IPOM. We have discussed, and with any surgery there will be some complications. We also discussed in brief about the complications also. Thank you everyone for watching this.
Doctor, what is the ventral hernia?
So it's a defect in the fascia of the anteroabdominal wall with or without any bulge. So that is the definition of ventral hernia. Anteroabdominal. What is anteroabdominal wall? It is made up of skin, subcutaneous tissue, fascias, aponeurosis, and abdominal wall muscles like external oblique, internal oblique, transverse abdominis, and rectus abdominis, and the peritoneum. So any defect through this may cause ventral hernia formation.
How to classification ventral hernia?
So according to the International Hernia Guidelines, so it's classified broadly into the primary and incision hernia. Primary, as we discussed, into 3 to 5%. So mainly it's the umbilical or epigastric hernia. Incision hernia, it occurs in 2 to 20%. Then once again, it's subclassified into midline on M1 to M5 and laterally into the L1 to L5. So this is about classification according to international hernia guidelines.
Doctor, what is the risk factors involved?
So mainly obesity, smoking, so there will be collagen defect, alteration in the collagen formation, and steroids. And when there's a patient with cirrhotic liver disease, ascites, distension of the abdomen, this or the one, malnutrition, wound infections, postoperative wound infection, and during the abdomen type of the incision what we used, midline, paramedian, transverse, or fenestrine incision what we used, the type of suture metal used during closure, and the tension used during closure, and the technical aspect of the wound closure. That makes the risk factors for incision hernia formation.
Doctor, how to diagnose ventral hernia?
So mainly one is by clinically. To confirm the diagnosis, mainly we can use an ultrasound to see the site of the defect and the content of the defect, or any other missing Swiss cheese effect like other defect is there. So when it's a big hernia, large hernia, or loss of domain, we can use a CECT abdomen to know the abdomen wall muscle architecture. So we can plan the surgery, how we can plan the surgery easily. One type of repair can be planned.
Indication for surgery, doctor?
So mainly the patient coming with the bulge in the defect or associated with the pain or discomfort over the bulge. That's the one thing. Other thing is progressive increase in the size of the swelling. That's the one thing. And skin changes over the bulge like redness or blackish discoloration. This is the thing. And irreducibility. When the swelling which was reducible previously, it's become irreducible. Sometimes cosmetic purpose. And last one is emergency, signs of obstruction like pain, vomiting, constipation, or obstipation. These are the indication for surgery, laparoscopic ventral hernia repair.
Doctor, can you briefly explain about surgery?
So surgery, there is a different one is open technique. The type of surgery we do, one is open or laparoscopy. We mainly use laparoscopic ventral hernia repair. Mesh, we'll use a mesh or prosthetic placement is the standard repair. So we'll use a technique IPOM or IPOM plus. IPOM means intraperitoneal onlay mesh without closing a defect, which can be done within when the defect is less than 2 centimeter. When the defect is more than 2 centimeter, we can use IPOM plus. It's called intraperitoneal onlay mesh with defect closure and placement of mesh.
So, doctor, what are the advantages of laparoscopic ventral hernia repair?
Because there will be a less tissue axis trauma, incisions are less, so scar are less, cosmetically better, less dissection when it's a simple hernia. When there's an incision, complication will be there. So less pain, early recovery, so shorter hospital stay. These are the things.
Why IPOM only? IPOM plus only, doctor? We can use other technique also.
Because IPOM plus, it closes the defect. There will be less chances of seroma formation, less eventation. The movement of the mesh, the movement or migration of the mesh into the defect, that may cause, that's called eventation, and there will be less chance of recurrence and better restoration of the abdominal wall function. So we can keep the mesh properly and low morbidity, less wound infection, less morbidity.
So complication of surgery, doctor?
So any surgery will be associated with some complications like seroma formation due to dissection or dissection in the sac. So it may cause fluid collection, which is called seroma. Sometimes bleeding may occur, which is called hematoma. And during the complex hernia, when there is a dense adhesions, during addusolysis, there will be a bowel perforation, or also called enterolysis. It may occur in 1 to 6%. So then that time we have to close the enterotomy. We should not use any mesh in that time when there is a gross contamination. Other complications like trocar site infections, wound infections may be there, or some small chance of recurrence. These are sometimes bowel obstructions may occur.
Doctor, can you give any tips to ventral hernia patients?
That's what. So there's a laparoscopy is a good surgery for the ventral hernia repair. If it's a small or medium size, we can do IPOM plus. When there's a large, when there's a loss of domain, we have to use a component separation technique or abdominal wall reconstruction technique. So that's the one thing. So I suggest all the patients to undergo laparoscopic repair because less incision, early recovery, fast recovery will be there, less pain, and less chances of recurrence. So there will be less tissue dissections and all. So I will prefer all the patients to undergo any defect, anteroabdominal defect or ventral hernias to undergo laparoscopic management of hernia repair using a mesh. That's IPOM plus. So this is my advice regarding the laparoscopic management of ventral hernia repair.
Thank you, doctor.
Namaste.